Welcome back. Happy October, Richard.
Oh,
It's we're into the final quarter of the year. Believe it or not.
I can't. And it's getting darker sooner.
Yeah.
So that's a sure sign that fall is here or coming. It doesn't feel like fall here in Florida.
It's a little bit less humid though.
It's what?
It's a little bit less humid.
Not yesterday. Well, it was very hot yesterday.
Yeah.
So in Florida, it's hard. You watch football games from around the country, and you see other places where they have sweaters and coats, and here it's 91 degrees yesterday, right?
Yeah.
So but it is fall. It is October, and so we're getting ready for Christmas, from what I understand. People tell me that I don't go to stores, but people tell me who do go shopping that the stores, the retail outlets, are gearing up for the holidays.
Yeah, it is just that time. But
I understand, and I understand there's not going to be anything to buy this year because all the ships are out and they're not able to unload their cargo. So my wife told me it's going to be Dad's kind of Christmas this year. There won't be anything to buy, So
I'm sure that there will be plenty to buy.
Relatively speaking, there'll be nothing to buy. But,
right.
But yes, it is fall, and it is October, and I can't believe in the last quarter of the year.
It's gone by very, very quickly. But today's podcast isn't about any of that.
Nor is it about COVID.
It is not. It's not about COVID, and it's not about the end of the year. Today, we're going to talk about. It's a topic we've talked about before, but we're going to just kind of review it again. And we found this interesting article that sort of takes a fresh look at borderline personality disorder.
Exactly. It's one of those topics that is always present, and it keeps coming around, and people continue to ask about it. And so we thought, well, maybe. So we started to nose around in the literature, and lo and behold, we found that there are some controversies with the diagnosis. And we thought, well, let's take a look at it and bring everybody up to date.
Well, and I suppose we should say that as it relates to that there's sort of controversies around all of the personality disorders. When it comes to things like anxiety and depression and ADHD and all those kinds of PTSD and all those different conditions, we tend to think of them as sort of individual conditions. Now they overlap. Depression and anxiety co-occur quite frequently, but we tend to see them as separate diagnoses. And a lot of times when we talk about personality disorders, we tend to think of it the same way, but yes, there's this entire area that talks about, personality is much more fluid as it relates to, you may have some traits from over here and over there, and, you may present differently in one circumstance versus a different circumstance. And so personality disorders are really difficult to talk about in general. But borderline personality disorder is especially challenging because it is such a complex and can be very, very difficult, very challenging condition.
Right. The personality disorders themselves, and there are 3 groups of personality disorders, always frequently present a diagnostic challenge because they are difficult to articulate, define clearly. And you often get the feeling, at least I get the feeling, that the diagnostic and statistical manual, the folks who developed that manual, someday are going to take a close look at the personality disorders and say, let's take a fresh look at these things and see. Some are easy, narcissism is pretty easy to do, but the other personality disorders are sometimes difficult to fully articulate exactly what they are. And then that assessment becomes difficult and intervention becomes difficult. And I think of all of them, this notion of a borderline personality disorder may be the most confusing of all of the personality disorders.
Absolutely. And so, just to quickly kind of give a very brief, we could spend days talking about what personality even is,
Right.
you know, but just to think about sort of a foundation that will work from, you know, when we talk about personality, we're talking about, you know, sort of the way in which you see and interpret and interact with the world around you. Now, unlike some of the clinical diagnoses that we talk about, again, like depression and anxiety and ADHD and OCD and those kinds of things, personality is sort of the underlying perspective that that is just the way that you do it. It's not like it's one way, you know, that you have an episode of personality and then you have another episode of personality. It's like it is the overall general way all the time. It doesn't change. It may make you more susceptible to erratic behavior or impulsive or unpredictable behavior, but it doesn't change episodically like we see with mood disorders or some other conditions.
Right. I always think of it.
World.
Yeah, I always think of it as this is who you are.
Right.
You know, day in, day out, this is who you are. But
Right.
it also relates to how you think about yourself, who you are, and also your relationship to other people.
Right.
Part of the personality, all the personality disorders have something to do with how you relate to others. Okay.
Right.
But it is characterological. It is who you are. It doesn't fluctuate from day to day.
Right. And so some other vocabulary that we've introduced in previous podcasts are the issues of egosyntonic and egodystonic.
Right.
And so when it comes to personality disorders or personality in general, they tend to be what's called egosyntonic, meaning that it's the way that you see the world and think about yourself, and you're typically under the impression that everybody else sees it the same way. Whereas egodystonic suggests that you know that you see it or feel it something different than what other people do. And so with personality, we tend to think of it as syntonic because, you know, I see the world this way because that's just the way that the world is to me. Right. Everyone else must see the world the same way because that's just the way the world is.
Right. No, it's as I view it.
Right. Right.
Right.
So when it comes to borderline personality disorder, and I guess the personality disorders suggest that the way in which we see the world sometimes causes problems. It creates difficulties interacting with other people. As you said, you know, it affects the way in which we communicate with other people, the way that we view other people, the way we value other people, the way we value ourselves, and all of those factors. And so when there are problems associated with that leads us into the world of personality disorders.
Right.
And one of those is borderline personality disorder. Right.
And as we say, probably the most problematic, I think, of these. Someday, I think we've done podcasts in the past where we've walked through all three clusters, what they call them clusters of personality disorder. But of the three clusters, this one, borderline personality disorder, creates the most confusion of all of them. Right.
To cluster B, which is also where antisocial personality disorder is, where narcissistic personality disorder. So there's other disorders in that category or in that cluster, that cluster B, that makes, and it does, you know, that cluster is amongst the most complicated and challenging personality disorders.
Yeah, they really are. Now, this whole term, this idea of borderline, maybe is the place where the confusion really begins. The term was first used. All of this personality stuff comes out of the European tradition, the psychoanalytic tradition that Freud started, and the term was first used in 1938. It was first described in the United States in 1975. The term borderline personality disorder was first used in 1975. And the head of the man who's considered the father borderline personality disorders, a fellow by the name of John Gunderson. He died recently in 2019. So this is current work, and I mentioned his name because we're going to be talking about another expert at the end of this, and she happens to be the director of the Gunderson Personality Clinic at McLean Medical School, which is affiliated with Harvard. But it was Gunderson who did the pioneering work in this field, and he was the one who described the characteristics that we now use in DSM-5. It was first described in DSM would have been 3 in 1980, DSM-3 in 1980. And he was the one who first described the symptoms that we use today. It's classified, as you said earlier, as a personality disorder, which means it has something to do with how the person relates to himself and other people.
Right.
Now, where it gets complicated, and this whole notion of borderline, why borderline? The problem with borderline personality disorder is it's so complicated.
Right.
The signs and symptoms there's a lengthy list, and I always hesitate to read off this list, but I don't know how else to avoid it. The problem is it's the complication, the overlap with other disorders, the amount of comorbidity that exists with other things, and just the sheer list of characteristics that are associated with borderline personality disorder.
Right. And as you suggested, the name itself is very complicated because there's nothing specific that we're saying that it borderlines. It doesn't borderline this and between this and this. It's sort of on the border of a lot of different things, from mood disorders, because some of those characteristics includes rapid shifts in mood, anxiety because of intense fears of things like abandonment. It borders on the area of thought-related disorders because of misperceptions of reality sometimes that happens where there's some interaction, and the person with borderline personality disorder may view that interaction in ways that are very different than what other people that are there view it. So it's sort of on the cusp of a lot of different conditions, and as you said, which really complicates the presentation, the diagnostic approach to it, and makes it really hard to be clear when it comes to diagnosing it.
Right. In our field, we talk about neurotic disorders and psychotic disorders. I mean, shorthand. Neurotic disorders are things like anxiety, irrational fears. Those are kind of neurotic disorders. And again, this goes back to Freud. So we have to remember this stuff came from that psychoanalytic perspective. Psychotic disorders are breaks with reality. There's something wrong. You don't deal with the real world.
Right.
There's some fundamental flaw in how you view the world.
And when it's used in this term, in this way, we're not talking necessarily about psychosis specifically like schizophrenia. We may be talking about schizophrenia or mania, for example, or sometimes some of the real severe anxiety disorders even result in sort of this break and disconnect with what's really happening around the person. So it's not necessarily talking about psychosis in a diagnostic way, but sort of a class of conditions that create a little bit of that break from what's really happening around you.
Yeah, we're not talking about people who have to be managed in institutional settings, necessarily, right? But this borderline seems to fit somewhere between the neurotic disorders and the psychotic disorders, And I think the reason it got stuck there is because there are some people who have very severe symptoms, and the symptoms are so severe that they start to look like the things that we typically associate with psychotic disorders. Nobody wants to call it that, so it's kind of in between. So the word borderline is this in between thing here, but that doesn't simplify and that doesn't clarify the problem with borderline personality disorder. And that's what we need to That's what we need to work on.
Right. And so we have this overlap with borderline personality disorder symptoms, with all of these other things, as we mentioned, depression and anxiety disorders, and substance abuse disorders, and a lot of different things. And because of that, we tend to see misdiagnoses.
Right.
For example, many times a person may be diagnosed with bipolar disorder, for example, because of rapid mood fluctuations, mood swings. Well, one of the characteristics of borderline personality disorder is rapid shifts in mood that happen very quickly and throughout the day. I'm not saying that everybody who has mood swings like that is borderline personality disorder, but that kind of confusion happens very often, even in professionals, when they're trying to examine some of this.
Right. And that's where it gets complicated, because we say on the one hand that it's somewhere between neurotic and psychotic, but all that does is tell us that this is a very complex disorder.
Right.
And one of the things that I didn't know, well, I knew from studying it, but this disorder isn't even listed in ICD-10.
Right.
Okay. Most disorders are listed in DSM and ICD. This disorder doesn't even exist. There's a comparable name for the condition, but the term itself doesn't exist there. And one of the problems we get into is the primary problem is the complexity. Number one is the complexity of this disorder. It just looks like many other kinds of things.
Right.
The second problem is that there's a full spectrum, as with many disorders, from very mild to very severe. And when you get to the very severe end of the spectrum, it begins to look like many other things. Okay. And so the symptoms of borderline personality disorder overlap with depression, of course, because it looks like a mood disorder. It looks like anxiety. People with borderline personality disorder frequently have eating disorders. It looks a lot like PTSD. There's frequently a substance abuse component. And as you said, it can look like bipolar disorder.
Right.
It looks like this kind of frenetic mood frequently occurs in people with borderline personality disorder. So it just looks like many other things. And so one of the reasons we wanted to talk about this today was because frequently people come in and they will ask, I think I'm borderline is typically how they put it. But as soon as I hear those words, I think, okay, this is a complex, multifaceted picture.
Right. Yeah. And and it's usually that a person has one of those characteristics or traits, and they look for they're looking for it online, trying to get a better understanding of it, and it comes up. But when it comes to the etiology or where, how it comes about, there is a bit of controversy with that as well. We once thought that it was related genetically, but there's actually not a lot of evidence, not a lot of strong evidence to suggest that that's the case. Where it looks more probable as it relates to the etiology, we need to look at neurobiological stuff, but especially neurobiological as a consequence of psychosocial factors like abuse and neglect and abandonment and some of those types of things.
Right, that's right. And I think that's where we're probably going to find more valuable information, because the neurobiological and the genetic hasn't really produced much of value yet. The research is not producing much, but we do know that there are certain psychosocial factors, such as neglect, abuse, and attachment, that could be causal, or at least highly correlated with borderline personality disorder.
Absolutely. And if we think about, we were talking about personality earlier and how it is sort of who we are and everything. We don't really think about personality until adulthood. We don't think about personality in children or anything like that, though. It is important that we recognize that we are born with a temperament, and anyone who's had a couple of kids knows that they can recognize that you have one child that was born and they were very easy, and they adapted well and adjusted well, and then the next child may be a little bit slow to warm up to things, or maybe a little bit more difficult, and that's from birth. Those temperamental characteristics are present at birth, and that sort of lays part of the foundation that will later become one's personality. But what is built upon that partial foundation is then all of your experiences. So if you have a bit of a challenging temperament, difficult temperament, and then you have neglect and abuse and attachment problems and some of those kinds of things that really develop and build this sort of unsteady structure that is your personality, then you're at increased risk for developing something like a borderline personality disorder or some other personality disorder.
Right, but it begins with temperament.
Right.
You start with that because, as we said, this is about the person that you are.
Right.
But we now know that your personality can be affected by life events.
Right.
And things can change, especially during the trip through adolescence.
Right.
Things can change dramatically.
Yeah.
So there are these environmental and family factors that can shape or misshape a person's personality. That's why we talk about attachment and abuse and neglect, because you can have a certain temperament when you're a year or 2 or 3, but if you suffer abuse and neglect, it's going to reshape that basic temperament.
Absolutely. And if you think about, this is why there's some of the complications as it relates to a genetic predisposition, because you can imagine if you have a parent with borderline personality disorder, so that their personality is going to affect the way that they interact and engage and see themselves and see others. That person then raising a child, there's going to be some relational issues there that can then contribute to an increased risk for that child to have it. And so it's not necessarily genetic in nature.
Exactly.
It may be part of that environmental exposure and stuff. And all of this, the diagnosis, all the more complicated because, it's, as we said before, as part of this cluster B from the personality disorders, but it's so complicated because we don't have very clear and decisive criteria and experiences that we can say, okay, because this, like bipolar disorder is relatively straightforward, as complicated as a diagnosis that is as well, it's relatively straightforward because if a person has a manic episode, that person has bipolar disorder. The diagnostic criteria is very clear. If you have a manic episode, you have bipolar disorder. With borderline personality disorder, it's much more complicated because you can have all of these different symptoms and still it may or may not be borderline personality disorder because it could be a lot of other things. So I think you're muted, Richard. So I think that, it makes that complicated because it, again, of that overlap with everything else.
Right. And even if you look at the diagnostic criteria, the official diagnostic criteria in DSM-5, as helpful as they are, when you look at them, so for example, the first one is chronic feelings of emptiness. Who hasn't experienced that? And emotional instability.
Right.
There it starts to look like borderline, bipolar disorder, because you have instability, but it looks like a lot of other mood disorders. Frantic efforts to avoid real or imagined abandonment. Once again, we see the effects of attachment issues here.
Well, and that could even look like a separation anxiety.
But it looks like separation anxiety, right? And so when you read through these symptoms, you get the same feeling that, wow, this could be a lot of different things.
Right.
Okay? And so that's where this becomes, one of them is impulsive behavior.
Right.
There are whole categories of different types of impulsive behavior throughout the diagnostic and statistical manual. Self-harm is another one, paranoid ideation, dissociative symptoms, and we're going to talk about dissociative disorder in a later podcast. But again, there's all this symptom overlap.
Right.
And that's the other thing that makes this so difficult. There isn't a defining characteristic. And that's why when people say, well, she's must be borderline, the implication there is that there's some defining characteristic.
Right.
There isn't a defining characteristic.
Right.
There are all these characteristics that have to be carefully sorted through and make sure that you're looking at borderline and not something else.
Absolutely. Absolutely. So when we get to issues of diagnosis, we have all of those issues, all of the issues related to symptoms, but then you have issues related to when can you even make the diagnosis? Because sometimes we see some of these behaviors in adolescence, and is that part of an adolescent angst, or is this an emerging personality disorder? And so it's really difficult to know, when you're working with a 15, 16-year-old, if this is something that we need to be concerned about from a personality perspective, or is this something else that's going on?
That's right. And we were cautioned in our training not to make this diagnosis prior to either late adolescence, 18, 19, or early adulthood, because at 14 or 15, it's a pretty good chance that you're going to change over the next 5 or 6 or 8 years. And so we're hesitant to say, this is who you are, and that it's a personality disorder. So what we do is we say, possibly an emerging personality disorder. There are some characteristics here that suggest that this could be a personality disorder, but it's just too early to tell. And I think it's too early, probably prior to early 20s. Or at least late adolescence.
Absolutely. And then you have, again, as we mentioned, the overlapping symptoms, but then there's the issue of comorbidity, and there is a high risk of comorbidity where you can have, and I think one of the most complicated comorbid conditions with borderline personality disorder is comorbid between borderline personality disorder and bipolar disorder. And there's some evidence in the literature that those two things can happen together, and that results in talking about a complicated condition already, that even makes it more complicated.
Right. I had one case like that where a person had both, and it was a very difficult thing, legally and professionally, to sort out. It ended up in a court case, but it's a very difficult thing to sort through because there's so much symptom overlap between those two.
Absolutely. And so what we really need to think about with borderline personality disorder, once you make the diagnosis, or once you see what's really going on, then we get to the idea of treatment. And treating personality disorders in and of themselves is extremely difficult. I mean, imagine working to treat someone, treat the way that someone sees themselves or someone sees the world. It's the framework through which you see everything in your life.
That's right.
Treatment is then geared to try to adjust that, and it's really difficult.
We used to think that, and in fact, one of the problems with with borderline personality disorder, I should just say BPD, is that we used to think that you couldn't treat it.
Right.
And that was one of the problems, that there was no treatment. These are characterological issues, and but you can't. The problem is that because it's not a single symptom, about 75% of people who have BPD are on some type of medication, but it's not to treat BPD, it's to treat the symptoms that occur with BPD. So if you have a mood disorder, or you have anxiety, or you're depressed, we can prescribe medication for that, but you don't prescribe medication for BPD, because it's like, I'm going to prescribe a medication for your personality. That's not how it works. That's not what you treat.
Right, and it makes me think a little bit like about what we talk about with autism. The indication for autism isn't to treat autism; it's to treat symptoms the co-symptoms that are associated with it. So the irritability, or the inattention, or the rigidity, and it's the same thing with personality. And so, many of those individuals are on mood stabilizers to help with
Right.
that fluctuation. They may be on anti-anxiety medications to help with some of that fear and those kinds of anxieties. And then, of course, antidepressants and things like that for other depressive symptoms and mood-related symptoms. But
Right.
there's not a medication that is designed specifically for your personality. Now,
Right.
I will say that there has been some recent research looking at the effect of some new medications,
Right.
like and some medications that would make some people very anxious to
Right.
think about, things like psilocybin,
Psilocybin, right?
and other hypnotic, hallucinogenic types of medications,
Right.
substances that have been used clinically to help treat personality disorders. And surprisingly, those have been much more effective.
Right.
In some of the early trials, at least, some of those have been more effective than other medications.
Exactly. Right. And that's a new area that we've talked about. You and I have talked about talking about those
Right.
sort of, but we're a little bit hesitant to venture into that because it is so new and much of the research has yet to be done. So we say there is no drug for BPD. It's the same with non-drug interventions. Right. There isn't a non-drug. People will say, well, let's do CBT or let's do DBT or let's do this or let's do that. Let's do exposure. We have the same issue. BPD is not a single entity.
Right.
And so therefore there's no single treatment.
Right.
You have multiple aspects to this disorder. Somebody with borderline personality disorder might be highly anxious. Then you have a non-drug therapy for anxiety, right, or depression or mood instability or emotional meltdowns or some degree of paranoia. Okay. And so you have to, the clinician must sort through the various aspects of this person's borderline personality disorder and then develop treatments for each symptom, if you will. So right. It's the same with psychological interventions, or like pharmacological interventions. You have to choose the ones to treat the symptoms.
Right. And there are some that people tend to use more often with PD, and that's like DBT, like dialectical behavioral therapy, and some of those things. And what those focus on is the history of trauma or the history of abuse, and they're focused on a particular aspect, hoping that by treating those aspects, it's going to affect the way in which they see the world. But it's again you're not treating the personality specifically. You're treating some of those characteristics or traits associated with it.
Right. And so all this controversy, if you will, leads to some discussion in the professional psychiatric community of whether or not we should even rename this thing. Maybe we should come up with a different name. And some people say we should, and some say we shouldn't. The psychiatrists who say we shouldn't make the argument that it's not bordering on anything. There's no border here. But we do know that it's somewhere between mild neurotic disorders and major psychotic disorders, so somewhere in between. But that may not be explanatory. It may just continue to confuse people. Also, that there's a temperament issue, an inherent temperament issue involved in this, and it has something to do with our inability to regulate our mood. Okay, that a large part of BPD is the inability to regulate one's mood. Well, that would make it a mood dysregulation disorder, make it a mood disorder. So the argument continues. Other people say that there's really nothing wrong with the name. It's not really, we acknowledge that there's a negative connotation, but maybe the negative connotation comes from, we don't know what to do about it. Well, we do know what to do about it. It's just very complex, okay? And so the current director of this, I mentioned the Gunderson Personality Disorders Institute at McLean Hospital. The elements are that the acknowledgement is that BPD is probably akin to a mood disorder. That everybody agrees with that. But it's also related to trauma. And many of the characteristics of BPD are the kinds of things that we now associate with trauma, whatever has been experienced. And the psychotic disorders, it's associated with the psychotic disorders because in a very severe expression, we will see not permanent loss of contact with reality, but at least a temporary short loss of contact with reality or with realistic thinking. So yes, it does border on those things, but it's no reason to get rid of the whole diagnosis. It's a kind of don't throw the baby out with the bathwater sort of issue. Okay.
Right. Yeah. So, as this new, we're thinking about this new way to consider borderline personality disorder. These experts, these researchers are looking at some of these characteristics, and they're trying to sort of whittle it down to the more fundamental aspects of what's resulting in, or the reasons why some of these things are manifest. Person with borderline personality disorder. And as you said, much of that is emotional dysregulation.
Right.
Because if you consider and think about how emotional and mood dysregulation influences us, it can get to the point where you have those, detachment from reality. It can result in that difficulty, managing the way that you feel and interact with those around you. And so, there are a lot of people saying that really at the fundamental aspect of this is a mood dysregulation.
Right. So our thoughts on this after going through all of this information, and especially the controversies surrounding it, we have a few conclusions. One is that we too easily say, we professionals will often say, oh, she's borderline or he's borderline, as though there's some defining characteristic, but there isn't.
Right.
When you teach this stuff to introductory psychology courses in introductory psychology, when you talk about borderline personality disorder, you try to explain it to people, but you quickly get into a more complex explanation. There isn't a single defining characteristic. You can't say this makes her borderline, this makes him borderline. It's far more complex than that.
Right. Another thing is that, as you said, there's not a defining characteristic. And so it's what, personality disorders are what we call characterological. It's who you are. It's sort of everything. It's not just one thing, it's everything. Right. And many times there are many who think that means that there's nothing that we can do about it. I mean, if you see the wall and the wall is white, it would be akin to trying to do therapy to convince you that that wall is not white. The way that you see the world is not correct, and you need to think about it differently. And so it leaves some professionals, or many professionals, with the impression that there's not really anything that we can do about it. Right. So they don't treat it at all.
Or they don't recognize the complexity of that. When you venture in, if you're going to treat people with borderline personality disorder, the first thing you have to acknowledge is that it's incredibly complex. There are going to be multiple symptoms, and you're going to have to, at some point in the therapeutic process, you're going to have to deal with each of those things.
Right.
Okay? It's not a simple solution, and it's not going to be a single approach. There are going to be multiple problems, going to be multiple symptoms, and you're going to have to sort through them one at a time and develop different therapies for each. It's almost, we talk about dissociative, it's almost as though you're dealing with a different person for each of those symptoms. This person has some depressive symptoms and some anxious symptoms and some relational symptoms and some dysregulation symptoms. And it's almost as though you're dealing with multiple people. You're not, but you're dealing with multiple problems.
Right. And along with what, we mentioned earlier with that idea of ego syntonic versus ego dystonic.
Right.
one of the things that's really important when it comes to treatment is that, and the challenge that many professionals have in working with people with borderline personality disorder is that the patient, the patient has to recognize that some of these things are a problem.
Exactly. And
so
that's another huge issue.
Right. Because, and for this reason, many people with borderline personality disorder don't even seek treatment because they don't see anything wrong with what's going on.
Right.
So, if you or somebody presents with some of these symptoms that we've talked about, it's really important to seek treatment from a professional that you trust, and that you are, that you will be okay hearing some really challenging things from.
Right.
When we treat this, there's a lot of confrontation. There's a lot of, tell me why you chose to do that. Right. Tell me why, some of this reasoning and everything. But the person, the patient has to be able to recognize that some of these behaviors are problematic and that something needs to be done about it.
That's right. And that agreement between the client, the patient or client, and the therapist is absolutely essential, because you're going to be working through some very difficult and sometimes very personal issues.
Absolutely.
And if you offend the patient in some way, they're simply going to leave. They're going to walk out. And so this treating people with bipolar disorder is not for the faint of heart. Borderline personality disorder is not for the faint of heart. Right. It's very difficult because it's so complex, but it's also very personal. And the patient or client must, and we're not imposing this on them. I'm not saying they must do this for me. I'm saying that they really need to bring some commitment to it. They need to say, yes, I have a problem. Yes, this is a problem. Remember that borderline is in the same category as narcissism. It's in the same cluster as narcissism. And if a person comes in and doesn't think they have a problem, first of all, they're not going to come in. If they don't think they have a problem, they're not going to darken your door. They're not going to bother coming in. And so there has to be some agreement here, because there's much work on the client's part. There's a lot of work that the client is going to have to do, and they're going to have to trust you.
Absolutely. Okay. Absolutely. So yes, it's very challenging, challenging to diagnose, very challenging to treat, and it requires a lot of trust and commitment, which is something inherently difficult for people, who struggle with this. So those who seek treatment, not only is it, great for them to be seeking treatment, but it is a sign of tremendous self-awareness and strength for them to overcome some of these inherent traits and characteristics that they have. They're going to overcome those to seek treatment, and that's just very commendable and fantastic. So
that's right. So if you ever get this diagnosis, or you think you might have this diagnosis, again, because of the complexity, we would really encourage you to seek professional help with someone that you feel that you can really trust, because it does take work, and it is very, very complex.
Absolutely. Absolutely. So, all right. Well, I think that's it then for today.
How was my chair today?
It wasn't too bad.
Not too bad?
It didn't click, and
my chair clicks for some reason when I move around in it. But
you move too much.
That wasn't a problem. Okay, good. All right. It's again, happy October, right?
Yes, you too. Enjoy the weather, and until next time, stay happy, stay healthy, and forget to be afraid.